As a cancer survivor myself, I can empathize with my patients in a way that they may not get from their typical surgeon or doctor. And it's just super rewarding to restore something that they've lost or something that was really taken from them.
Dr. Aisha Baron is helping Black women take their power and their beauty back.
Representation matters within the field. I have college students, high school students, medical students, to kind of get my perspective on the field. If you can't see it, you can't be it. The thing about the cancer diagnosis is that personal control is taken away from you during that process, and that can even be more daunting than the actual diagnosis. We choose size together, we choose the operation together. My staff is super supportive to my patients to make sure that they have what they need. I try to give some of that decision making within reason because it's tough to go through. They think it's a vanity, and it's totally not. You literally are about to or have had a functional body organ has been removed. It's not like you're just having a mole removed or something like that. It serves a purpose. Reconstruction is not the end of the story. For many women, it's the beginning of healing.
Today's guest is Dr. Aisha Baron, a board-certified breast and reconstructive surgeon. She's also known as the breast and body doctor. She's not only a leader in the operating room, she's also a cancer survivor who brings empathy, artistry, and empowerment to the women that she serves. Dr. Baron, tell me what drew you to this work.
What drew me to this work was just being around women. I've always wanted to do women's health. At first I thought I wanted to be an OBGYN, but then in residency, my heart got drawn towards surgery. And there's so much variety within plastic surgery. And so I knew that I wanted to do something that would, cater to women and give them a greater sense of self. So in addition to cosmetic surgeries, a large part of my practice is breast reconstruction. And as a cancer survivor myself, I think that I can empathize with my patients in a way that they may not get from their typical surgeon or doctor. And it's just super rewarding to restore something that they've lost, or something that was really taken from them.
Sure.
I think it's just super rewarding, and it's something that I strive to, really help women with, if I can.
It's my understanding there's not a lot of Black female plastic surgeons in the United States. You're among a very distinguished small group of women. Tell me a little bit about that.
Yeah, so, I think now it's probably only about, 2 to 3% of all physicians are Black women. And, when you talk about in surgery, it's typically like an old boys club. More women are getting into the space, which is great. But, I'm probably 0.1 or 0.2% of all plastic surgeons, out there. So during training, sometimes that was a little challenging, but, I think it's just a blessing, that I can be in this space and be a representative. Representation matters within the field. I have college students, high school students, medical students, so many people reaching out to me to kind of get my perspective on the field, just because if you can't see it, you can't be it, and so I think with my history of being on a reality show that featured us as surgeons, it really broadened the base so that people could really see, like, okay, there are Black female plastic surgeons. I'm still seeing people who come into my office as a result of that, who, that visibility is just so powerful. And the fact that it's still rewarding and still driving people to my practice is great.
So when you are seeing more young women, Black women coming in for breast augmentation or reconstruction, I should say, consultation, what is the first, walk me through that process, what you do with them and how you determine what's the best route?
Right. So when a patient comes in, whether young or old, and they come in with a breast cancer diagnosis, first I tell them that I'm sorry that we are meeting under these circumstances, but that they'll be able to experience the pink lining on the dark cloud of breast cancer by, being treated by me. I go through all the options with them. I do comprehensive breast reconstruction, meaning I do all forms. There are some surgeons out there who only do implants and they only do local tissue flaps. But I do implants, expanders, I do local tissue flaps, and then I also do microsurgical reconstruction.
Oh, what
in
is
which,
that?
it's pretty intricate. Microsurgical Microsurgical reconstruction is where you transplant tissue from one part of the body to another part. So one of the most common ones is called the DIEP flap, and that's called the deep inferior epigastric perforator flap. And that's where we take the abdominal tissue and dissect out an artery and vein that goes to it on each side, say if we're doing both sides. If we're doing one, we only do one side. But we then transplant it up to the breast and connect that blood supply with the operating room microscope. So it's a very intricate, very detailed procedure. Only people who have been trained to do it, really do that, just because it can be a little bit of a longer procedure than, say, implants. But it's super rewarding because patients, if they have enough tissue, you kind of get the benefit of a tummy tuck, and then the restoration of your breasts. So it's good to have the option to use your own tissue because later on down the line, you won't have to get anything exchanged. You won't have to get implants exchanged. You won't have to, the complication profile is much less because it's your own tissue. It will gain weight with you, it will lose weight with you. And as long as it survives that initial stage after the operation, then it's yours.
Okay. So I know I've heard people have to get the expanders. Tell me about that, because I've seen, unfortunately, some people had infections with their expanders as well. So I'd love to learn more about that process.
Right. So one of the most common forms of breast reconstruction is an implant-based reconstruction. And so sometimes that can be done as a one stage in which we go direct to an implant, or it could be two stages in which we may put a tissue expander first, allow the skin of the breast to recover from the trauma of a mastectomy, because a lot of that initial blood supply is stripped away then. And so we let things heal with an expander in place and then bring the patient back to the office several weeks later, and then start our expansion process. And so that expansion process, typically the patient comes every couple of weeks to the office and gets saline, or sometimes people use air, to fill up that expander until they reach their desired size. And so the patient...
Is that painful?
No, the expansion is typically not painful. Some patients may have some soreness or some heaviness, especially when they're towards the end of the expansion. But now a lot of surgeons have moved towards putting the expanders on top of the muscle so that it is less painful. Okay. Before we were putting it underneath the muscle. And so sometimes that could, make for a little bit of a more uncomfortable experience when it comes to the expansion because it has to stretch that muscle out. So now it's not typically very painful for patients. It's super tolerable, but we'll let the patient reach their desired size. And then about 2 to 3 months after that initial placement, we'll go back to the operating room and exchange that expander for an implant.
So if someone gets a mastectomy, we understand that. But what about when they have a lumpectomy?
So if they have a lumpectomy, and depending on what their breast looks like and where the tumor is, a patient may be a candidate for something called breast conservation surgery. Okay. And so that when we do breast conservation, that's the lumpectomy. And then we can do oncoplastic surgery. And so that's basically just rearranging the tissue on the breast to fill the void where the lumpectomy was taken. And so a patient will either have a breast lift or a breast reduction in order to tailor that tissue and get them aesthetically pleasing breast while filling that defect so that they don't have a lump or a divot or a depression there.
So that gives the symmetry that they need too.
Absolutely.
Okay. Is it better or is your recommendation, someone's been diagnosed with breast cancer, when do they need to call Dr. Baron to the table?
So typically when a patient's been diagnosed with breast cancer, it's preferred if they, see their either breast oncologist, if they're at that stage yet, or their breast surgeon. So their breast surgeon, their surgical oncologist, is the surgeon that removes the cancer. So they do the lumpectomies, they typically do biopsies, they also do the mastectomies. And then if the patient wants reconstruction or is a good candidate for reconstruction, typically they will refer to a plastic surgeon such as myself. And so that's the stage normally where I see a patient immediately after that first consultation with the breast surgeon.
So this is before any surgical procedures are done?
Yes. And so some patients may have more advanced disease, and because they have to get chemo or radiation or, something like that, they may not see me immediately, but typically they should have a consultation prior to any surgery has been performed. Just because if we can preserve some of the natural skin on the breast, then it makes for a better looking reconstruction. It decreases complications. But there's a disparity that exists in which Black women may not be offered breast reconstruction as frequently as their counterparts at the time of diagnosis. And so, I even see women to this day in which they say, well, I'm here for reconstruction. And, I ask, well, did you have radiation? Did you have advanced disease?
Sure.
And they say no. But they just never offered me breast reconstruction. They didn't refer out.
And that's typically when you're a cancer patient, it is more than likely going to be covered to some extent, I would imagine.
Absolutely. There's a Women's Health and Reconstruction Act of, I think, 1998 that basically said if you have insurance and you have surgery for breast cancer, then your reconstruction will be covered.
Okay. Let's talk about the recovery process. And also, do they have to have those implants replaced, I don't know, every decade or?
Yeah, so the one thing with implant reconstruction is that it can provide a beautiful reconstruction. The only thing is that you may have to have that implant replaced, every 10 to 15 or 20 years, depending on how it holds up. A lot of the implants that we have now are a little bit more form stable, and they will last a little bit longer. But we do know that the longer implant sits in the body, sometimes the shell can degrade and you might get a silent rupture. So it's just important for patients who have implants to maybe see their plastic surgeon or reconstructive surgeon once a year, once every 2 years after they've graduated from that reconstruction process.
And so the recovery time for the average, if they're getting like a full, like double mastectomy, for example.
So a double mastectomy with implant-based reconstruction, typically that recovery can range anywhere from about 2 to 4 weeks, depending on the patient. In my practice, I use some long-acting numbing medications, and then also have a pre-op and post-op med protocol that helps to decrease the need for narcotic use. And so a lot of my patients are pretty comfortable after surgery and may not have to take that much. And so they may feel that they have a shorter recovery. But, pain is subjective. Everybody has different levels of pain, so we always want to make sure that we're being sensitive to that and making sure that people are comfortable in their recovery. Now, if we're talking about mastectomies with a larger operation like the DIEP flap surgery, where we're using your own tissue, that's a little bit more of an extensive recovery. You spend about 2 to 3 days in the hospital just to make sure that the blood flow remains intact between those vessels. And then once you get home, your recovery is probably going to be about 4 weeks until you start feeling like your normal self again. So it's similar to like a tummy tuck recovery.
Okay. And the emotional concerns that kind of go with any kind of reconstruction, do you advocate for them to do any mental health counseling in conjunction, or you leave that up to the survivor? It's an emotional decision. It's an emotional process.
Yeah, so typically, like the breast surgeon's office where they've been referred to will kind of spearhead that because they
Okay.
have that infrastructure in place. They'll have nurse advocates, things like that, to where they'll have, mental health resources, therapy available for the patient. But I also do offer up to my patients to speak to past patients. There's some women in which this reconstructive process is so daunting for them, and they can't really wrap their mind around what they're about to go through. And so I think what's really helpful is that I have some great patients who will get on the phone and let them know the process, and let them know how their experience was. And I think that's important to get a firsthand account
First person.
of what you might be going through. Every year I have a breast reconstruction awareness day.
Okay.
And that's in October. It's been it's a day that was created by our plastic surgery organizations, and I typically host an event at the office. And year by year, I see some of my patients from different spans of time in my career, and they come together, and some of them have made friends, and they've asked questions, and it's just a good way for them to kind of really fellowship, and they can share their experiences and really just celebrate themselves.
That's wonderful.
So I think having those resources built within a practice, I think, is definitely helpful, so that the patients know that you can talk to someone who's been through it, not just someone who does it.
So we talked about those who have been diagnosed with breast cancer looking for reconstruction. The woman who has not been necessarily diagnosed, say she's over 40, before you're moving forward with your reconstruction, are you saying, I want to know that you've had your latest mammogram? Is that part of that conversation with that patient?
Yeah, so I mean, with any patient that comes in for any type of cosmetic surgery or even reconstructive, I do make sure that they're up to date on their mammograms. I feel like I ask almost every patient if they have a history of breast cancer in their family. But yes, I definitely make sure. I will not operate on a patient if they've not had adequate screening prior to surgery, just because I've had a couple of patients in which on doing a breast reduction. Initially, their screening was completely fine. And we got in there, did the breast reduction, and the pathology came back as like having a small cancer. Wow. I've had 2 patients in which that's happened to. So even though we did everything that we were supposed to do, sometimes things can be kind of hiding or lurking. So I think at least we covered those bases,
right? Exactly.
But the patients, typically are just very grateful because they're like, oh my gosh, if I hadn't have gotten this breast reduction, or I would have found it much later.
Yes, that's true.
So I think it's important to, just check all the boxes before you go into surgery.
And what about post-surgery? How do you recommend they take care of their breast health in terms of the implants? Is it only ultrasound and MRIs, or can they still get a 3D mammogram? Because the squeezing of the mammogram, I would think, does that bother the implants?
Right. So I think patients really are only encouraged to get mammograms after reconstruction if they still have breast tissue. So if they've had a lumpectomy and they still have the majority of their breast tissue, then they'll still get mammograms. But if they've had mastectomies and they have implants or a flap in place, there's not really an indication to get a mammogram because the 95 to 97% of the breast tissue has been removed. So typically examinations, because you're most likely to feel a recurrence in the skin, as opposed to it's not going to come back in the implant or in the flap tissue. So I tell patients to make sure that you examine yourself, in the shower every day, know what feels normal, know what seems new. In addition, if there's something that comes up and is questionable, then a patient would get like an MRI or potentially an ultrasound. But when it comes to checking the integrity of the implant, then an MRI or ultrasound is helpful to make sure that it hasn't ruptured.
Okay. And I guess, is there ever an age that is like maybe a little too old for that reconstruction? If someone is, I don't know, 70 plus years old, and Is that recommended, or you're a little hesitant about that? Or?
Right. Yes, I could definitely be hesitant in some patients. I want to say the oldest patient I've probably done breast reconstruction on was maybe around 74. She was young 74, so I look at the entire patient. If someone exercises, takes care of themselves, does not have a significant amount of comorbidities, other medical issues and things like that, then yes, if they want reconstruction, I think it should be an option for them. They will get a more simple reconstruction most likely, as opposed to maybe like a big flap or something like that.
Something more involved.
But yeah, you have to look at the entire patient and not just basically have an age cutoff. Just because I feel some people you wouldn't even be able to tell that they're in their 70s, if they really take care of themselves.
Right.
So yeah, I don't have a hard cutoff, but they got to pass the eyeball test.
Are you seeing a lot more Black women seeking reconstruction when they're particularly younger ones that are being diagnosed? Because as I don't know if you know the statistics, but Black women under 35 are 2 times more likely to be diagnosed and 3 times more likely to die. So are we seeing a trend of a younger clientele coming in and looking for that reconstruction to give them the balance and symmetry that they're looking for?
Absolutely. I think we're seeing that uptick because screening has improved. Screening, detection, and those things have improved. And so you're going to catch these things earlier. So it's just natural that your demographic of patient eventually will become younger as you have these more patients being diagnosed early. So yeah, I mean, do I see more women in general? No, because I feel like I always see the women, the people who seek me out are gonna, are majority. About 75% of my breast reconstruction patients are Black women.
Wow.
But yes, I am seeing younger patients, and I do feel that the younger patients are more apt to want reconstruction. They still have plenty of life to live. But there are some women who opt to go flat and don't want reconstruction.
Really?
Yeah,
Okay.
Absolutely. So I think that's also a choice that should be discussed with the plastic surgeon, because some people just don't want a ton of surgeries or even 1 or 2 surgeries afterwards.
They've been through so much.
Yeah, they've been through so much. And they say, some women are like, I've never really been attached to my breast. It's not common, but
Right.
You have to honor that request and that desire not to proceed with that process in patients as well. So I'll never push a patient towards reconstruction. I just lay out all the options, and no reconstruction is always there too.
What do you want a woman to know about reclaiming their body after diagnosis?
After diagnosis, I think, however women choose to reclaim their bodies is really up to them. I try to provide as much information as possible so that they can make an informed decision. I think they can reclaim their bodies by, being in charge of, or, working with me during the reconstructive process. As a cancer survivor myself, I didn't have breast cancer, but I had lymphoma at around 27. I've done chemo. I know what it's like to have your life turned upside down by a diagnosis. And so I think they can really claim their power back through the reconstructive process. And I try to lend that back to them. My office is very flexible with, appointment times and scheduling, just because they can be pulled here, there, and all over the place. I always say that, the thing about the cancer diagnosis is that a lot of personal control is taken away from you during that process. And that could even be more daunting than the actual diagnosis.
Yeah.
You have this dream or this plan for your life, or even for like the rest of the year, a vacation or whatever.
Everything's turned upside down.
All of a sudden you're told you have to go here, you have to do this, you have to take this, you have to stop this, all of these things. And so I try to, reclaim that power through the reconstructive process. Like, we choose size together. We choose the operation together. My staff is super, super supportive to my patients to make sure that they have what they need. And so I think I try to give some of that decision-making, within reason, back to the patients during the process, because it's tough to go through.
And you're in private practice, if I remember
Yes, I
correctly.
have my own practice. It's called Breast Body Beauty, Plastic and Reconstructive Surgery. It's in Smyrna, Georgia.
Okay. Anything else you'd like to share with our listeners about the reconstruction process as it relates to breast cancer?
I think, the reconstructive process, it can be a beautiful experience. It doesn't mean that it's without complications sometimes, so some patients may go through complications, but I think as long as you have a surgeon that's really there with you every step of the way, and, you can develop that relationship of trust, then I think it makes it all the more easy. I think a lot of times breast cancer patients, they really latch onto their breast surgeon, which is super important. However, you will spend most of your time, if you want reconstruction, with your plastic surgeon afterwards. So it's really important
Develop that rapport.
that you like your plastic surgeon and trust that surgeon, because after the cancer is out, you may go to follow-ups with your breast surgeon, maybe right after surgery, maybe once or twice a year or something like that afterwards. But you're going to see your plastic surgeon probably pretty frequently for those first couple of years after a diagnosis. So I think it's important that you develop a good relationship with them.
Do you see or hear women expressing shame or guilt for wanting potentially reconstruction?
Yeah, sometimes patients will come in and they will say, I was never the person to, consider plastic surgery. And here I am having to get plastic surgery. They think it's a vanity, situation, and it's totally not. And when patients come in and they say that, they'll say, well, don't think I'm vain, by wanting to reconstruct my breast. And I say, you're not vain at all. I said, you literally are about to or have had an organ, a functional body organ, has been removed. Something you developed over your life, is being removed. It's functional, it's not like you're just, having a mole removed or something like that. Like, it serves a purpose. And so, it's a reconstructive procedure. It is medically necessary, because not having a breast for many women, it really impacts their self-esteem, their body image, their feelings of self-worth,
intimacy,
their sexuality, and so I think it's not something to be taken lightly, like, oh, okay, I'm just, I'm going to the plastic surgeon to get this done.
Right.
It's a reconstructive process. It'd be no different than someone, getting fitted for a prosthesis or something from, having an amputation, So because they do have, plastic prosthesis or whatever, but this is really just reconstructing that organ that has been removed, or that body part that has been removed, and it's medically necessary. There's no vanity about it.
One question we talked about young women being diagnosed more often and seeking the reconstruction route. A lot of them are at childbearing age. Does that prohibit now, when you're getting the mastectomy and then you're getting the breast reconstruction, if they use their existing tissue, does that restore their opportunity for breastfeeding, or is that pretty much off the table?
No, that's off the table. So once the breast tissue has been removed, then there's no gland, there's no breast tissue that would produce milk or would lactate. So when we use your abdominal tissue to transplant it up there, it's abdominal tissue. It's just abdominal fat.
Okay.
It mimics the texture of breast tissue. So that's why it's our number one go-to option. But I tell patients all the time, you can rest assured that the flap will not form breast cancer, okay? Because it's just fatty adipose tissue. It's not breast tissue. So it doesn't have actual breast cells. So they can be, pretty confident that after that type of surgery, it's not going to form breast cancer. But yes, it does not restore function, afterwards. In the same way in which if a patient has a nipple reconstruction after a mastectomy, it typically is numb. And so it really is there for an aesthetic marker to, restore the aesthetics of the breast, which are super important as well. But a lot of patients will ask, well, if I do a nipple reconstruction, will I be able to feel it? And unfortunately, they typically will not. You may get protective sensation, like hot or cold or pressure, but you won't get any erotic sensation or anything like that, or fine touch from those reconstructions.
Yeah, I forgot about the nipple preservation, and then there's a lot of, I think there's the tattooing.
Yeah, so there's tattooing, in which some patients, they don't want an actual 3-dimensional nipple reconstructed. They'll opt for a 3D areola tattoo, in which the breast will be completely smooth and flat, but sitting from where you are from me, some people may not be able to tell that they don't have a physical nipple there. So the tattoo artist will create shading and use different dyes or inks in order to create the look of an areola as well as a nipple. And so that's been super transformative. Like, some of them are so phenomenal. It's
it's permanent.
Yeah, it's permanent. Sometimes patients might need to get a touch up, but I mean, the artistry is amazing at what they're able to create.
Interesting. Well, you have shared a lot of information on breast reconstruction, and I think bringing that balance back to a survivor is so important because, like you said, something has been taken away from them, and you're restoring that beauty and balance to them so that they can continue on to the next chapter in their lives. And so we thank you for what you do, and there's such a small percentage of wonderful, esteemed Black plastic surgeons in particular, let alone just Black surgeons in general.
Right.
So you're in a special elite group of very skilled women, and we thank you for what you do.
Thank you.
Thank you.
Thank you. I appreciate it. I appreciate the opportunity to speak on this because it's super important. You get to a point to where you feel like everybody already knows about breast reconstruction. They should, or you feel like they do know, especially me since I talk about it. But, every day, I encounter patients that, have no idea. And it's just this nebulous kind of concept for some people. So any way I can help educate is always, a way in which I give back, and it's rewarding.
I love that you shared about the coverage aspects with the, Reconstruction Act.
Yeah.
Because I think, that's on a state level or federal?
It's on a federal level, I believe. However, the insurance companies, they've been acting kind of crazy lately. So some insurance companies have been denying reconstruction on some patients, claiming that it's not medically necessary. And so they're trying to find loopholes in some of the policies. It doesn't happen often, but when it comes to revisions, a lot of companies are denying revisions, when before that was unheard of.
And a revision is?
Revision. So if you had reconstruction like 10 years ago or something, and you need to have the implant exchanged, or, if you want to change your reconstruction and, get an implant removed and do the flap, some insurance companies are, making it difficult to have the procedures done. Okay. And in addition to that, they are cutting reimbursements for surgeons significantly.
Wow.
Which is really unfortunate because, we have to keep our offices open.
Sure.
In order to offer the service to patients. And so it's really frustrating when you're battling these big corporations, on behalf of the patients, and, when they tell you no, or they, cut your reimbursements by 75% sometimes.
Wow.
It's like you want to offer the service, but you also have to keep your practice open, so, and you have employees to pay and everything. So, hopefully, the tide will turn and change, somewhat, in which, surgeons are adequately compensated. The patients can get the procedures and the surgeries that, they deserve and really are entitled to. So yeah, we could just hope that, they do the right thing.
Well, we know that if they come to you, they're going to get good information and compassion, care, which is so important.
Yes, it is.
Thank you.
The motivation working in oncology is easy. I think we all have a family member or a friend that's affected by cancer, and you just know the toll that takes on not only that person, but their their family.
While I might not today be in one of those situations where I desperately need a medicine for someone I care about, millions of people are all over the world in that exact situation. Like, we are the people who make those things.
No shortcuts, no compromises. We discovering, we identifying, we applying cutting-edge technologies and the methodologies in our daily work.
Whether I can improve with new technology, doing something faster, I'm always trying to get better in every experiment that I'm running.
I think we constantly have to be pushing those boundaries, not just so that we can stay at the forefront as a science and technology company.
Being bold with ideas can really help us make breakthroughs and bring us a step closer to discovering effective treatments for patients.